Let me first introduce myself. My name is Artem Stepin. I'm a head of cardiac surgery department in Ural Institute of Cardiology in Yekaterinburg, Russian Federation. And the name of our research is Dynamics of Hemoglobin Levels in the perioperative period in cardiac surgery patients using ferric carboxymaltose. Next, please. I would like to share with you brief results of our research first. The study objective was to investigate hemoglobin dynamics in the perioperative period during intravenous use of ferric carboxymaltose in cardiac surgery patients. It was a retrospective single-center study. First group included 113 patients who received ferric carboxymaltose infusion in the perioperative period. The control group was the same number of patients, was matched at blood propensity score analysis from 1,042 patients without such infusion. We figured out that the ferritin level in the first group increased from around 40 to around 600 microgram per liter after the infusion of ferric carboxymaltose. The difference was significant. And at the same time, we observed a significant increase in hemoglobin within 24 hours after the infusion and in the early postoperative period in first group. At the same time, the decrease in hemoglobin level at discharge in first group was significantly lower in compared to group 2. As investigating safety, note that as we recorded in first group, the incidence of infections complication did not differ significantly between groups 2. Next slide, please. As you know, it's a global prevalence of anemia reached 25%, and it is not surprising that the number of patients with anemia can reach around 80% in cardiac surgery departments. The 5% decrease in perioperative hematocrit level associated with increase in risk of death by 8%. And the risk of renal failure by 22%, and risk of infection complication by 10%. And as we know, the likelihood of blood transfusion is 3 times higher compared with patients without anemia. Next, please. When diagnosing iron deficiency, we can use actually as main source of information a complete blood count, including hemoglobin level, erythrocytes, reticulocytes, the volume of reticulocytes, and other parameters. We use also biochemical blood test when we can calculate serum ferritin as a main parameter to diagnose iron deficiency, and saturation of transferrin as the second one important parameter. When we treat iron deficiency, there are 2 main ways. We can administrate medicine orally. It takes a little bit longer, and then it's another way to treat it with parenteral iron preparations. We use it actually when we need to control iron deficiency quickly or with severe form of anemia. Next, please. The criteria for anemia and iron deficiency well known. The classic criteria based on WHO is hemoglobin level less than 130 in men and less than 120 in women. Target level more than 130 is strongly recommended before major cardiac surgery, regardless of sex. And classic criteria for iron deficiency is ferritin level less than 10-20 milligram per liter. It is a classic sign of iron deficiency, but in such chronic diseases like heart failure and other, ferritin level may reach 100 milligram per liter because of chronic inflammation. Transferrin saturation coefficient is also important criteria to diagnose iron deficiency. Existing protocols make it possible to actively identify patients with such a disease and treat them orally or parenterally. Intravenous forms of iron allow rapid correction of iron deficiency directly before cardiac surgery procedures. However, the dynamics of hemoglobin in these settings have not been fully studied. Next, please. We conducted a retrospective single-center study at the Department of Cardiac Surgery in Ural Institute of Cardiology in Yekaterinburg. Patients were stratified in two groups by sex and type of the intervention, and pseudo-randomization propensity score matching was performed according to a left ventricular ejection fraction, creatinine level, and predicted mortality by Euroscore 2. We investigated the level of hemoglobin in 4 points: 0.1 at admission, 0.2 within 24 hours after intravenous iron transfusion, 0.3 postoperative day 1, and 0.4 immediately before discharge. Next, please. As you can see, both groups were comparable in such parameters as age, sex, Euroscore points, left ventricular ejection fraction, NICA functional class, creatinine. And of course, it was a significant difference in number of patients with anemia. We performed around 45% coronary artery bypass grafting, around 17 treatment of required heart disease and tumors, and around 40% patients were treated because of heart failure. Next, please. There is a protocol for prescribing and dosing ferric carboxymaltose. The iron deficiency was identified at ferritin level less than 100, and anemia was identified as hemoglobin level less than 130 grams per liter, regardless of sex. And if a patient had anemia along with iron deficiency, it was administered 1,000 milligram ferric carboxymaltose intravenously. And to patients with iron deficiency but without anemia, it was administered 500 milligram ferric carboxymaltose intravenously. When ferritin level was normal and there weren't any signs of anemia, only prevention of blood loss without ferric carboxymaltose was administered. Next, please. There you can see the dynamic of hemoglobin levels in the perioperative period in the patient with ferric carboxymaltose infusion, which were differ significantly from the control group. In first group, the mean hemoglobin level rises immediately after iron carboxymaltose infusion, as well as starting from the first post-operative day. Group 1 shows a biphasic hemoglobin pattern, rising after the infusion, then recovering faster post-surgery compared with control. Next, please. Key hemoglobin results. Increase in hemoglobin within 24 hours after iron carboxymaltosate complex infusion. Group 1, first group was around 4.3 gram per liter. And at the same time, ferritin increase was 15 times fold, from 40 to around 600 milligram per liter after the infusion. There was also increase in hemoglobin level in the early postoperative period in first group, which was significantly high in compared to second. And in the first group, it was 2 times less reduction in total hemoglobin level between the admission and the discharge, and consist around 10 gram per liter in first group, which was twice as small in compared to second group. Next, please. And it's a safety analysis, blood transfusion and complication. As you can see on this slide, surgical bleeding were actually 4 times higher in first group, but this difference wasn't significant. And the infection level was the same. We figured out one case of myocardial infarction with ST elevation in both groups, and then the stroke wasn't observed in first group, which was also comparable with second group. And in hospital, mortality was also comparable. It wasn't observed in first group. The need for red blood cell transfusion was low in both groups, and it was an average around 0.07 units of red blood cell transfusion. The difference wasn't significant. And around 80% of all transfusion cases in first group were associated with surgical bleeding rather than anemia per se. Next, please. And the same we can say about intensive care treatment and longevity of postoperative period. It was comparable, and in intensive care it was around 2.1 days in first group and 1.6 days in control. In postoperative, it was about 8 days in both groups, and the mortality was comparable too. The level of mortality was very low in both groups, no cases in first group and 1 case in control. So we can conclude the use of ferric carboxymaltose in perioperative period has a high degree of safety. It does not affect the development of fatal outcomes, thrombotic complications, or surgical site infections. Next, please. And it's literature data. We found 5 most important researches in this field, and it was discovered that the average level of hemoglobin after transfusion of ferric carboxymaltose ranged from 7 till around 17 gram per liter in different investigations in our study, the increase in the hemoglobin level after infusion of ferric carboxymaltose was a little bit less, around 4.3, which corresponds to the lower limit of the range described in the literature and is explained by a single administration very close to the surgery. Next, please. In conclusion, I would say that significant increase in hemoglobin is observed after a single infusion of iron within 24 hours after the infusion and in the early postoperative period in cardiac surgery patients. And it actually leads to reduced need for blood transfusion. 25% of patients who received infusion with ferric carboxymaltose did not require allogenic blood transfusions in the postoperative period. We observed also twofold smaller decrease in hemoglobin level. The overall decrease from baseline hemoglobin in the group of patients after the infusion is 2 times smaller by the time of the hospital discharge. And the study demonstrated high safety profile. The use of intravenous iron does not affect the risk of infection complications, thrombotic events, or death. Thank you for your attention.
Why does staphylococcus matter? Stiffen matter? Because arteries are not metal pipes. They should be springly. ATV makes them stiffer, and that is an early warning sign to heart and kidney trouble. Think of it as a blood vessel sending an SOS signal. The stiffness, what is it? It is ability of a structure to resist deformation and depends on the physical properties of the material to restore its shape after it has been altered. This characteristic has been used in relation to the arterial wall since the mid-20th century, when numerous studies by the Russian School of Cardiology were devoted to studying vascular resistance parameters, reflecting the ability of the arterial wall to resist the impact of a pulse wave. What is rigidity? Rigidity, translated from Latin, means hardness, the inability of an artery to respond to the expanding effect of a pulse wave, characterized to a large extent by excessive tension on the muscular layers of arteriole. And it is very important to differentiate stiffness and rigidity, because it is 2 different qualities of arterial wall. Our goal today: measure stiffness using simple tools, see how it links to clinical outcomes, and convince you that taking stiffness should be routine in HIV care. There are 3 aims, no paradox. 3 aims: to average arterial stiffness in HIV-infected individuals using oscillometric measures, including pulse wave velocity and augmentation indices, for accurate detection. Second is to analyze the correlation between increased arterial stiffness and clinical outcomes to understand its diagnostic and prognostic value. And third, to establish the significance of arterial stiffness measurement to guide management strategies in HIV patient population. Study design and patient enrollment include conducted a single-center cross-sectional screening study at Perm State Hospital named Tverye, following good clinical practice guidelines. The study included 240 confirmed HIV-positive patients diagnosed through immunoblood testing to ensure diagnostic accuracy. Obtained written informed consent from all participants before study procedures altering the ethical standard. Complied with ethical mission to maintain study integrity and regulatory compliance. Exclusion criteria for our study participation was so that we excluded patients with malignancies to avoid confounding effect from cancer-related vascular changes, Omitted individuals exhibiting deviant behavior to ensure compliance and reliable data collection. Patients with acute decompensated heart failure or cerebrovascular accidents were excluded to isolate chronic cardiovascular status, and excluded those with severe purulent septic condition and congenital heart defects for a homogeneous study group. And we split patients into groups. Group 1, it is stiff arteries. The criteria of stiff arteries was index of augmentation and peak wave velocity more than 10 millimeters per second and augmentation index more than 10%. And there was only 28 patients in this group, and a group of comparison was 212. No signs of increased arterial stiffness with method of tensiometry, angiometry, non-invasive. And of course, then we start to find some difference between these two groups. We did a full workup, ultrasound, a non-invasive measurement of stiffness arteriography by tensiometer, blood test, even alcohol screening with the audit scale. Because life still matters, and what people drink or don't drink can affect their vessels. And what did we do? We measure the main indices of echocardiography and used equipment Vivid T8 and carotid artery Doppler ultrasound to assess heart function and vascular health. Otherwise, patient was underwent physical examination. Then arteriography and vascular resistance measurement by this kind of equipment. It is tensiometry. Tensiomet, it is European equipment, was employed alongside calculation of total peripheral vascular resistance, integrating blood pressure and cardiac output data. Then was done laboratory markers evaluation. Laboratory analysis included NT-proBNP level, TIMP1, ferritin, iron, and erythrocyte sedimentation rate to evaluate inflammation, cardiac strain, and related parameters in the patient cohort. Alcohol dependent screening include audit scale assessment, identified alcohol dependence levels, providing context for lifestyle factors potentially affecting vascular status. On this slide, you can see traditional Russian index of total peripheral vascular resistance. The first variant of this index appeared in the 60, 70 years of last century. And in our university, it was used and it was estimated firstly by the professor Zubarev Mikhail Anatolievich with his unique method of heart investigation, computer polyreocardiography. Polyreocardiography with impedance measurement of the chest and with the different indices of impedance was possible calculate total peripheral vascular resistance. Now with this professor, now he is 84 years old, he is my teacher, we adapt his formula for usual echocardiography, and it looking so. That total peripheral vascular resistance formula with usual echocardiography parameter, and it can and hemodynamic blood pressure parameter need what's there in this formula. Average hemodynamic blood pressure in millimeters Gidrargen calculated from the linear equation. One part from 3 of the blood pulse pressure plus diastolic blood pressure. Then 0.133, it is coefficient for converting millimeters Gidrargen to kilopascal. So then the coefficient for converting milliliter to liter. SV, it is a stroke volume calculated according to echo medications, a diastolic volume minus systolic volume in milliliters, and heart rate, the heart rate per minute. Very simple formula. This formula is unique. because it gives possibility to get information not from large arteries stiffness like in tensiometry, but from the arterial stiffness. Stiffness of arterial, it is the index of future, index of long life, active life, life duration, and condition of total health, index of total health. It is very important index. I think that in future these parameters will be the same the same line as lipoprotein of low density, for example, or body mass index, because it is very important parameter too. We use this traditional statistical analysis procedure. Zero data normality was assessed using Kolmogorov-Smirnov and Shapiro-Wilks test to determine appropriate statistical method. Comparative analysis employed Mann-Whitney U test and chi-square test with Yates correction to evaluate group differences robustly. Correlation were analyzed by Spearman's rank correlation, while predictive value was assessed through odds ratio and risk calculation. And on this slide, you can see clinical characteristic by stiffness key findings, which most interesting in our this work. Smoking, indication of smoking, rise of stiffness a lot. If we'll continue that group 1 and group 2, more smokers was in group 1 with the stiffness in arteries, which was detected by tensiometry. Comparison of smoking prevalence, alcohol dependence, and cardiovascular disorders rate between groups defined by arterial stiffness status. Increased arterial stiffness correlate with higher smoking rates, low alcohol dependence, cardiac conditions show no significant group difference. Later I will demonstrate for you in other indexes. And of course, on this picture, you can see that if patient smoking, his stiffness more high. But if he ATV patient, but he is alcohol dependent, he will have less index of stiffness. Alcohol depends decrease the stiffness of arteries. Maybe it is funny. Of course it is funny. Drink alcohol and it will be good for you. No, it is not good. It will be another complications. But in this situation, it is a clinical paradox. Not all bad in somebody. That something good need to be definitely. Next picture demonstrates comparison of echocardiographic results. And you can see the main difference which we revealed. It is main pulmonary artery pressure. It was more higher in patient from the fourth group, and pulmonary artery hypertension cases was more in percentage than in group without stiffness. That means it is an indication that stiffness not only peripheral arteries, but stiffness of the pulmonary artery and its branches present symmetrically. And here we can see that affection of pulmonary artery with its branches present very bright, very intensive, maybe more intensive than the peripheral arteries. Also, we can see left atrium volume in prevalence in group with arterial stiffness. And of course, it all connect these two processes, pulmonary artery hypertension and left atrium volume enlargement. I hope that all you remember the works of 19th and start of 20th century from the Russian internal disease school. There are lived a very famous professor, Fyodor Kitaev, and he described a reflex of Kitaev, which is a reflex of spasm of arteriole, of pulmonary arteriole, which protect body from pulmonary artery hypertension. And this is the reason why enlargement of left atrium present and pulmonary arterial hypertension present. It means a total stiffness, total arteries affecting affection present in patient with HIV. Now, I demonstrate for you augmentation index. Augmentation index more rise in group number 1. It is presented for both groups, demonstrating high arterial stiffness and altered vascular complaints more in group number 1 compared with group number 2. Elevated augmentation index in group 1 strongly correlates with pulse wave velocity, confirming increased arterial stiffness and impaired vascular complaints in this group. Pulse wave velocity as a marker. What does it mean? Pulse wave velocity exceeded 10 meters per second in group 1, aligning with clinical threshold defining increased arterial stiffness. This parameter effectively distinguished patients with elevated vascular rigidity. The clear differentiation by pulse wave velocity correlates with recognized cardiovascular risk factors, reinforcing its value as a non-invasive marker in assessing vascular health among HIV individuals. And this slide, you can see distribution of arterial stiffness by risk factors. The chart emphasizes the higher prevalence of smoking in patients with increased arterial stiffness and low incidence of alcohol dependence in this group. Smoking strongly associated with greater arterial stiffness, while alcohol dependence appears inversely related to arterial stiffness, suggesting complex interaction with vascular health in HIV patients. Then we can see hemodynamic data comparison with total peripheral vascular resistance. Comparison of total peripheral vascular resistance, stroke volume, and heart rate between groups reveals hemodynamic difference linked to arterial stiffness. Higher total peripheral vascular resistance in group 1 reflects increased vascular resistance, supporting the association of arterial stiffness with adverse hemodynamic effects in HIV patients. We can see that in group number 1, a reduced stroke volume, increased heart rate, and elevated total peripheral vascular resistance. On this picture, you can see clinical characteristic, clinical indexes, some of them, not all, but some of them more often interested by our colleagues. These are age, male gender, 6-minute walk test, present of chronic heart failure, smoking, alcohol consumption, and antiretrovirus therapy. And you can see that but only 2 indexes here I marked that smoking and alcohol consumption. They demonstrate a different or another note with method of tensiometry. Then echocardiographic and laboratory parameters present. And we can see some difference between 2 groups. Group number 1 with a higher stiffness, no difference in NT-proBNP, but level of serum iron was less. TIMP1 level was more higher, and all of you remember that it is the index of fibrosis. Erythrocyte sedimentation rate was more higher in this group. CD40 cells was less, but not exactly. You can see that P level not different a lot. Ferritin level was not different so much, but left atrial enlargement present more clear in group number 1. More patient, 60.7% was with enlargement of left atrium, and in the group number 2, only half of them. And middle pulmonary artery pressure, it was more high in group number 1, and pulmonary artery hypertension, 60.7% in group with stiffness, and 39.1% in group without high indexes of stiffness. This slide demonstrates laboratory markers and arterial stiffness correlation. Elevated cardiac strain and inflammation markers correspond with increased arterial stiffness. Indication systemic involvement in vascular damage among HIV patients. Positive correlation between biomarkers and stiffness measures highlight the role of inflammation and cardiac stress in vascular rigidity development in this population. And you can see that correlation with anti-proBNP level, TIMP, ferritin. Of course, it is very interesting. Here, usual indexes of this equipment. We wrote it in group 1 and group 2, that it's middle medians and quartile and different in P, and you can see that all of them was very different because it was a reason why we separate this patient into groups. Next picture demonstrates for you clinical implications of increased arterial stiffness. First, it is elevated cardiovascular risk in HIV patients. Increased arterial stiffness in HIV-positive individuals is linked to higher cardiovascular event rates, necessitating vigilant risk and assessment to guide timely clinical interventions and to improve patient outcome. Second moment, it is pulmonary hypertension as complication. Notable increase in pulmonary arterial hypertension among them with stiffness arteries underscores the importance of targeted monitoring and management strategies to prevent progression of pulmonary vascular disease. And third, it is a worsening hemodynamic profile demand attention. The association of arterial stiffness with adverse hemodynamic changes highlights the need for integrated cardiovascular evaluation, enabling clinicians to tailor therapies that optimize cardiac and vascular function. Predictive value and prognosis of our work. Arterial stiffness parameters effectively predicted the onset of chronic heart and kidney diseases in the HIV patient, confirming their role as early markers of end organ damage. About kidney disease I wrote too, because it is part of our work, but due to the limitation of time, I was not able to speak about kidney function too. Risk stratification analysis demonstrated that non-invasive stiffness measurement offer substantial prognostic accuracy for future cardiovascular events in this high-risk population. Incorporating arterial stiffness assessment into routine clinical practice may improve prediction and prevention strategies, ultimately enhancing long-term outcome for HIV patients. Of course, like in every study, presents study limitations and future directions. The study's single-center and cross-sectional design limits the broader applicability of findings across diverse HIV population and geographic settings. Future multi-center longitudinal studies are needed to evaluate causal relationships and track arterial stiffness progression over time in HIV-infected patients. Research should also focus on evaluation therapeutic interventions, specifically targeting vascular stiffness to determine their impact on cardiovascular outcome in this group. Incorporation of novel biomarkers and imaging modalities in future studies may enhance understanding of underlying mechanisms and refine risk prediction models. Integrating arterial stiffness assessment into HIV care. Routine evaluation of arterial stiffness in HIV-infected patients enables early detection of cardiovascular and renal risk, facilitation personalized interventions that improve disease management and patient prognosis. And last conclusion, HIV patients in 12.7% of cases have signs of increased arterial stiffness. Increased arterial stiffness was more common in smokers and less common in alcohol drinkers. Left arterial ladderment and sign of pulmonary heart failure was more often detected in the group with increased arterial stiffness. The changes of a rise in the volume of the left atrium against the background of increased arterial stiffness increasing 2.7 times. In patients with increased arterial stiffness, a low serum iron content was noted and increased activity of TIMP1, as well as increase in the rate of erythrocyte sedimentation. Thank you very much, dear colleagues.
Will be an article which I published recently in Curious. It's about pulse oximeter screening for critical congenital heart disease. This was a 4-year experience. We had it in our Women Wellness and Research Center in Qatar. The paper is authored by me and my colleague, Dr. Arawiya, Dr. Azam, Dr. Rima, which is our pediatric cardiologist and fetal-maternal echo-fetal cardiologist, Dr. Linda, and our case manager, Mr. Fatin Haridi. I would like to introduce to you first what do we have, and maybe you are not familiar with our hospital and our setup. Our hospital is it's one of the Qatar national medical hubs for women health in the Gulf area. We conducted almost about 18,000 to 200,000 annual deliveries. We are the biggest tertiary hospital in all the area, and I guess even the biggest tertiary hospital in all the Gulf area. We conducted, it's the premium tertiary referral centers for all high-risk neonatal and maternal, and we also had a very high-risk obstetric maternal fetal medicine. We have a very well-established fetal-maternal unit, which see all the high-risk maternal cases and all the high-risk fetal deliveries, and we prepare them before delivery. We also have a very active unit for the IVF and reproductive interventions. We also had a very integrating developmental follow-up clinics. I'm talking about only from the NICU side of view. We have a comprehensive lactational service and the National Family Center Care Program. Our NICU is a very advanced neonatal care and has a triad of excellence. We had almost 140 beds. Tertiary level, and it's one of the region, as I mentioned, largest and most advanced tertiary center in the country. We also had the features of what we call the tiny baby unit, which followed or looked after the extreme preterm babies less than 28 weeks. We had all the facilities for the ventilation, like high frequency jet ventilations. And usually we are not a surgical unit, so whenever we have a surgical case, we prepare it and then we stabilize and then send it to another hospital, which is Cedar Medicine, for all the surgical interventions. We have a very well-established neurodevelopmental team and hemodynamic team. We are the only transport system which is running all over the country. We are transporting babies across the hospitals in the country, and also we are getting babies from outside. We have active integration. We are affiliated with Wheel Medical Medicine, Wheel Cornell Medical College in Qatar, and also Qatar University. We are driving neonatal research, simulation-based educations, and we have a very good quality department which have initiated lots of quality improvement projects, and we are indulging this. We also have multidisciplinary teams and a family integrated care. So I just want to introduce our hospital, and then we'll move to our case, which is the vital rhythm, which is a pulse oximeter, which uses one of the neonatal safety nets. Our study evaluated the 4 years of universal screening for critical congenital heart disease in our Women Wellness and Research Center. We call it WWRC. And that's from 2017 to 2020. I'm presenting it, and I had the honor to present it in the Heart Congress 2026. So we know all the global burden of the critical congenital heart disease. We know that 1% of all babies live born, they have affected by congenital heart disease. But the problem that 25% of this congenital heart disease are classified as critical congenital heart disease. And what we mean by critical congenital heart disease, that those babies who need a surgical intervention or catheter intervention immediately, so at least they can survive. And the estimated percentage of infants with critical congenital heart disease who go undiagnosed within the first, especially, in the first few days of life, is really almost about 30%. And these babies, when they are undiagnosed and they're duct dependent, so they crash immediately because they appear normally at birth. So without any interventions, without any diagnosis, they can go for rapid deterioration, cardiovascular collapse, and neonatal mortality, which is happening usually in the first 3 days of life. What triggered us to do this was, as we know, only the babies who are becoming with symptoms, this is the tip of the iceberg. Most of them are hidden, become asymptomatic, because sometimes, we have, in this country, we have a diverse population. So we have babies which sometimes the cyanosis is difficult to be detected. And the females, sometimes we be felt normally, especially when the babies are like having still intact some ducts, especially the interrupted aortic arch. They can feeble pulses, which can really even be overlooked. So we had a very good antenatal detection based on, we have a very strong, as I mentioned, fetal maternal unit, or fetal cardiologist sitting there. And that fetal cardiologist, Dr. Rima, she trained almost all because the high-risk babies are coming, high-risk mothers are coming to this fetal maternal unit. What about the low risk, which sometimes pick up have also lots of abnormalities. For that, she made a very strong training courses for all the technicians, radiologists, to do this two views, the outlet flow and the four-chamber view. So this is the two critical things which we need to look at. So they're very, very much trained, and we get lots of referral from them. So we look back our data, we reviewed our WWRC institutional data, which almost at that time was 15,000 and now becoming 18 to 20. And we evaluate how effective universal pulse oximeter, we call it POC, to close this series diagnostic gap. So it was a real evaluation of the in this high census, or high volume. We have almost 18,000 deliveries per year. So this is a very high volume delivery. So our core objective was to evaluate the performance and diagnostic yield and clinical outcome on the pulse oximeter screening, which we call it POC, to optimize the neonatal cardiovascular care in Qatar. Our work starts from the global adaptation. We looked at what everyone is doing. We find that there is a very wide application for this POC all over the country, but we don't have data for our clinic, so our hospital, which is the main tertiary hospital in the country. So we started applying the pulse oximeter practice and to look what's going on, and we have different, what we call it, steps to evaluate the gaps and how to fix the proper and how to fix the screening process itself. And now, after we did this, we make it like a standard protocol for all babies before going home. And we have a quantity precision, precise false negative and the false positive rate within the massive WWRC infrastructures. We have almost 10 floors full of postnatal deliveries plus our babies in the clinic. So we developed a strategy which is now, alhamdulillah, implemented all over Qatar. So all babies before going home, they have the CCHD screening test done for them. Once they are admitted to the NICU and also when they are in the postnatal floor. So this was established by 2020, and from that on becomes the standard of care. As you know, this is a American Academy of Pediatrics adopted algorithm, which our target, for us, sometimes our target is to do it as 24 hours, but sometimes because of the high census and the high number of deliveries, we tended to do it at 12 hours of age. And this is sometimes to the bed capacity constraints. We have lots of deliveries and we need to have beds for them. So our target is most of them, like I can say, like 85% of these babies, they have their pulse oximeter done at 24 hours of age before discharge. And at 12 hours of age, if we have any constraints, but these babies, usually they get an appointment follow-up to check on them after 3 days. So we know that how we adopted the pulse oximeter screening, we put a probe on the preductal area, which is the right hand, and the postductal, which is the left hand, the left leg. And we need to have a difference which is less than 3, so this baby is safe. So if the baby is saturating more than 95, 94 on the right hand and foot, and there is no any difference, this baby is passed and he's cleared from critical congenital heart disease. If the readings were in between 90 and 94 in both extremities, we need to repeat it after 1 hour. If it's the same, if it's improving, becoming more than 94 with no difference, this baby passed. If it deteriorate, then he will have to go to the red category, which is the saturation is less than 90 or the difference more than 3 between pre and post. This immediately we call them failed CCHD screening, and immediate attention to the physician, and then escalation of support will come, other admissions and follow up and echo and all the stuff will be done for this baby. So our screening scale, we have almost at that period, our cohort was 68,000 births. We managed to identify 141 critical cases. Our population, after we removed the antenatal screening, it is almost a big number. And we ended by having 141 babies identified as CCHD cases. Some of them are, I will show in the next slide, some of them was antenatal diagnosed, and some of them were clinically picked up before the pulse oximeter, and the rest were picked up by the pulse oximeter screening. So pulse oximeter screening for us, out of all this cohort, identified only 8 diagnosed true CCHD cases, which is giving a detection rate of almost 1.17 per 10,000 live births. It also identified almost 26 babies of critical non-congenital heart disease, which we will show later in the next slide. So we have a tripartite diagnostic yield. We have a 141 babies, as I mentioned in this cohort, out of the 68,000. 74%, which almost half of the cases were diagnosed antenatally, this is the credit for our fetal cardiologist. And this is all diagnosed before delivery. And the postnatal one, which picked by clinically were almost 33 cases, which is 23.4%. And the median age of diagnosis, because these babies usually are examined at not immediately after delivery, but at least within 12 hours from delivery. So they all are picked up by our expert doctors. And the one we missed and not picked by because they, as we mentioned, the coming slide, they don't have murmur, they don't have any issue cyanosis. This is picked up by the POC detection, which is almost 34 cases, which is 24.1%. The median age was 6 to 12 hours of age. So nearly half of the critical heart disease were picked up antenatally. This is really the absolute credit for our cardiologists. And then we need another layer of postnatal, either clinical examination or screening before discharge from the hospital. If you look at the clinical profile of our cases, definitely they're all term babies. They're all in the postnatal. So definitely they have no any risk factors for being admitted to the NICU. So their weight will be range between 3.1 and 3.2 in all categories, which is antenatal, 74, clinical, 33, POC, 34. So the gestational age is almost the same, 38, 39, predominantly males. The upgirls were okay. That's why they're fine and stable in the postnatal ward. The positive POC examination or post-oximetry examination, definitely the antenatally were already diagnosed. Clinically, all of them, they don't have any abnormalities by the pulse oximeter, while 100% were picked by the pulse oximeter. The signs, the absence of heart murmur, there is too many heart murmurs in the clinical examination. So it's 15% they don't have heart murmur, while almost more than 75%, 80% they have heart murmur. 97% they have cyanosis. And absence of pulse oximeter only on few babies. While the pulse oximeter, the POC screening, majority of them definitely there is no murmur, no cyanosis, only plus the findings was the absence of the clinical, the femoral pulses. So infant caught by pulse oximeter lack the classical warning sign, which is the cyanosis and murmur, but they have the high incidence of absent femoral pulse, indicating adductor-dependent cardiac lesions. If we look at the antenatal and the profile, this is another reiterating or another way of mentioning how we get this data. And I'll thank for the notebook LM because it's amazingly doing all what you think about it. So the antenatal and clinical symptoms, usually heart murmur is predominantly present, tachypnea sometimes is present, but in the POC cases, usually they're asymptomatic, but they're critical. There's no murmur, no cyanosis, no tachypnea. Only sometimes the femoral pulse can make a clue, but most of them are detected by failed pulse oximeter screening. And out of all these cases, we identified almost 28 cases out of the 34. 28 cases were finally turned to be persistent primary pulmonary hypertension of the newborn. One of the hypoplastic case was detected by the POC examination. And some of them will have like tetralogy of Fallot, and one of them 15%, like 7 cases were detected by the POC examination with tetralogy of transposition of the great arteries. So our POC examination really detected all the serious conditions. Most of them were pulmonary, but also good because these babies were sick in the postnatal and nobody picked them up. So if you look at the decoding of the POC yield, and we have only 34 babies failed the CCHG screening, as you can see here, out of the 68,116 babies, 64 failed CCHG. The true cardiac were 8, with a positive predictive value of 23.5%. Most of them, there were TGA, hypoplastic, total anomalous pulmonary venous return. 26 were non-pathological, non-cardiac pathologies, which mainly, majority of them were PPHN, sepsis, and pneumonia. So no infant with true CCHG passed the screening algorithm, which is also signified the variability and the credibility of this screening tool. So if you want to look at the diagnostic yield of this pulse oximeter screening, it's not a complementary, it's a mandatory, it's a recommendation. So the antenatal scans usually done, as in our study, as I mentioned, it picked up most of the AV canal defects, and it allows our time to have proper intervention stabilization. But the blind spot, as I mentioned, is the outflow tract lesions like the co-arc and the TGA. That's why our fetal cardiologists were training the other technician radiologists on these two views, the outflow tract, the outflow view, and the four-chamber view, to make sure that these cases are not missed antenatally. This is how we fill this gap. And then the clinical examination, our specialists are properly trained, and they have to look, first of all, the most important, we said that you have to look for the femorals and definitely the cyanosis. But sometimes the blind spot is that babies are sometimes not asymptomatic, and they have dark skin, so this will mask the cyanosis. But the pulse oximeter usually, which we are doing, it yields about 24% of the cases. Which usually the strength of it, that it picked all the silent hypoxemia. If there's absent femorals, which is not detected, it can be picked up by the pulse oximeter. And the blind spot, it's taking acyanotic congenital heart disease, which is for us not a priority. I don't mean that they're not important, but at the same time, acyanotic congenital heart disease are stable. They can be picked up later, and there is no urgent intervention, and there is no risk of mortality and morbidity. So we created that we have a 3-layered defense, the Swiss cheese model for the neonatal cardiac neonatal screening, which is starting from the antenatal, clinical, and the pulse oximeter. And as we know that no single screening method is perfect, but POC acts at the last final defensive final barrier, ensuring that almost 100% detection of the critical hypoxemic lesion before hospital discharge. The blind spot, which always have, I'm sure most of the people, they have the same problem, is the outflow tract dependent, which usually not detected antenatally. And we know the coagulation of the aorta remains the global diagnostic blind spot. And usually the antenatal detection of these cases of coagulation in our cohort was only 50%, while the global rate was almost as low as 22%. And the pulse oximeter sensitivity is interestingly lower for the left-sided obstructed lesion like the coarctation, as they do not usually have immediate hypoxemia in the newborn period. This is also the blind area which we need to work and which can be corrected by having the pulse, femoral pulse detected. So the clinical yield of clinical examination plus antenatal plus the pulse examination, pulse oximeter examination will cover all these cases 100%. So we need to reframe staying false positive as it's not a false positive, false negative, it's a comprehensive safety net. So the POC examination, which the pulse oximeter screening for critical congenital heart disease, hold a 23.5% positive predictive value, specifically for structural congenital heart disease. The international standard is over 80% of the so-called false positive internationally present clinically meaningful systemic illness. So our finding in the WWRC finding that all false positive cases in our cohort was related to either clinical significant PPHN, sepsis, or respiratory distress. And we conclude that POC examination is not merely a cardiac test, it's a function. It functions as an essential early warning system for profound neonatal illness, directly elevating patient safety. So now the new standard of cardiovascular care in Qatar, we have a crucial complement, which is now we are using pulse oximeter, but not as a standalone test. It's a vital third pillar alongside with antenatal and clinical assessment. We found that POC examination successfully identifies structurally critical duct-dependent lesions and also those who appear asymptomatically. And even this universe beyond cardiology, the universal screening has a more safety border, especially babies who have PPHN and they stay in the postnatal floor. So we are continuing doing the audits and adhere to the standard 24-hour screening protocol, because sometimes we are deviating from it when we have high census, but it's really a very crucial and essential to eliminate preventable neonatal mortality. So the study limitations which we did, because we know it's a retrospective design, so we have limited by the documentation quality and reliance. And we have the time variation, which, as I mentioned, 85% of the cases were done at 12 to 24 hours of age, while only like the rest are done at 12 hours of age because of the high census. But these are giving a follow-up clinic, which is also closing the gap of the unreliability. At the center scope, single center scope when we started. So after we started and we have our result, we implemented all over Qatar. All centers are doing it. We lack in our study that we only looked at the babies who are in the hospital and discharged. So we assessed only the in-hospital detection. We missed the late postnatal discharge, but we'll continue collaboration with our cardiologists. We're checking all these babies, and luckily during the study period until now, we don't have any missed cases who come back to the cardiology clinic or come to the emergency crashing. So our safety net is over almost 100% over the last few years, and definitely we don't have a new developmental outcome, but this is our next paper, inshallah. So our conclusion that the layered defense models of neonatal safety only layer. One is the antenatal scans, which we need to train the technicians on this two image, the outflow tract image and the four-chamber view. As I mentioned, it catches 52% in our cases, and it misses only the outflow tract, but it's discovered now with training. The second layer is the clinical examination. We need to strengthen the issue of feeling the pulse, which is very important. Usually the hole in it missed the asymptomatic infant. The third layer is the POC screening, which is detected all the hypoxemia and invisible hypoxemia and systemic illness, which catch almost 24%. The final outcome is the integration of these three layers at our hospital at WWRC achieve near complete detection of critical cardiac and non-cardiac hypoxemic condition before discharge from the hospital.
Esteemed Chairman, distinguished members of the Presidium, colleagues, and guests, thank you for including our report in the conference program. I look forward to productive scientific collaboration and practical contacts. The topic of my report, tracheostomy in cardiovascular patients with bleeding disorders. Professor of the Department of Anesthesiology, Resuscitation and Emergency Medical Care of the Institute of Postgraduate Education. Doctor of Medical Sciences, Associate Professor of the Higher Attestation Commission. Ismailov Evgeny Petrovich Borzova Tatiana Mikhailovna, Kabachava Garina Vailanovna. Saifulin Rustam Rafikovich Samara Clinical Hospital No. 1 named after N.I. Pirogov. Relevance cardiovascular diseases CVD and anticoagulant therapy create a complex balance between the risk of thrombosis and the risk of bleeding anticoagulant coagulopathy. The use of anticoagulants warfarin, heparins, though it essentially creates a controlled hypercoagulation, which, if administered incorrectly or with concomitant pathologies, develops into acquired coagulopathy with a high risk of hemorrhagic complications. In acute coronary syndrome acts, coagulopathy most often manifests as hypercoagulability, a tendency to form thrombi, which requires the mandatory use of anticoagulants. To prevent myocardial infarction or its complications, the use of anticoagulants carries a risk of bleeding, so an accurate risk assessment is necessary. Especially in the presence of concomitant diseases, advances in resuscitation are largely due to improvements in respiratory support, particularly in the treatment of severe cardiovascular diseases with acute respiratory syndrome, such as myocardial infarction and unstable angina. Cardiac dysfunction leads to hypoxia, which in turn worsens the prognosis. In cases of grade 2 to 3 acute respiratory failure, patients with cardiovascular disease receive respiratory support via a laryngotracheal tube. However, if prolonged mechanical ventilation is expected for more than 7 days, it is advisable to create a tracheostomy to adequately clean the tracheobronchial tree, which significantly reduces the risk of laryngeal damage and reduces the risk of pneumonia. Prolonged MV carries a high risk of laryngeal damage due to tube pressure, causing ischemia, edema, ulcers, and cicatricial stenosis. The most dangerous periods are periods longer than 7 days, as well as intubation for more than 1 to 2 hours. Injuries include vocal cord damage, chondroperichondris, and necrosis, requiring preventive measures such as cuff pressure monitoring and timely tracheostomy. The main risks and consequences of laryngeal damage during prolonged mechanical ventilation: mucosa and soft tissue injuries, erosive and ulcerative lesions, hematomas, and mucosal necrosis due to pressure from the endotracheal tube cuff, laryngeal edema, development of edematous laryngitis, often observed after 4 to 7 days, cicatricial stenosis, narrowing of the larynx and trachea, a dangerous condition that occurs in 0.5 to 25% of cases of prolonged due to scar tissue formation, after pressure ulcers, vocal cord damage, development of granulomas, paresis, or paralysis of the vocal cords, leading to persistent hoarseness, dysphonia, or aphonia, chondroperichondris, inflammation of the laryngeal cartilages resulting from a laryngeal pressure ulcer, which can lead to necrosis, infectious complications, high risk of developing laryngotracheobronchitis due to impaired mucociliary clearance. To reduce the risk of mechanical ventilation for more than 7 days, tracheostomy is recommended. The problem is that these patients receive anticoagulants and have increased tissue bleeding. The aim of the study was to evaluate the experience of using an open tracheostomy technique in cardiovascular patients with bleeding disorders. Material and methods of research. The study was conducted between 2023 and 2005 at Samara Clinical Hospital No. 1 named after N.I. Paragraph. There were 13 men 56.52% and 10 women 43.47%, aged 73 to 63.9 years. The patients were admitted to the cardiology department, and examination and treatment were carried out in accordance with the clinical guidelines of the Russian Ministry of Health for acute coronary syndrome and cardiac arrhythmias. The nature of the patient's diseases is shown in ICD-10 codes. Permanent atrial fibrillation 148. 0 to 19 patients, pulmonary embolism 126.05, unstable angina 120.03, sudden cardiac death 146.11, previous myocardial infarction 125. 2. 1 aortic valve stenosis with insufficiency 135.2. 1 dilated cardiomyopathy 142.0. 1 mitral stenosis with insufficiency 105.2. 1. Recurrent anterior myocardial infarction 122.01. As their condition worsened, all patients were transferred to the intensive care unit, where they received respiratory support with artificial ventilation via a laryngotracheal tube. All patients received intensive treatment based on emerging complications, monitored by computed tomography, electrocardiography, and echocardiography, with coagulation profiles and blood biochemistry. Blood osmolarity and lactate levels were monitored, and cardiac troponins and blood gases were measured. The severity of the patients according to the Apache-E scale was 28.351 to 8. The risk of bleeding during tracheostomy surgery according to the Haas blood scale was 60.7 points. Within 5 days after the start of prolonged artificial ventilation, an operation was performed, the formation of a tracheostomy, a method for forming a tracheostomy. In case of coagulopathy, Russian Federation patent for invention No. 2,815,285. Ismail AVP et al. 2023. The surgeries were performed in the operating room, with patients transferred from the intensive care unit to the operating room, on an intensive care bed, without being transferred to the operating table under general anesthesia. The open tracheostomy technique involves preemptive hemostasis and tissue coagulation before incision, the use of a hemostatic sponge before wound suturing, and gauze pads in the wound, which were removed within 3 days after surgery. The surgeries were performed in the operating room, with patients transferred from the intensive care unit to the operating room, on an intensive care bed, without being transferred to the operating table under general anesthesia. The open tracheostomy technique involves preemptive hemostasis and tissue coagulation before incision, the use of a hemostatic sponge before wound suturing, and gauze pads in the wound, which were removed within 3 days after surgery. Tracheostomy. Surgical features. Patients requiring tracheostomy surgery are in severe or critical condition and require long-term respiratory support with mechanical ventilation. Any additional complications associated with tracheostomy worsen their condition. Therefore, the less trauma during the surgery itself or complications in the early postoperative period, the better for patients. A review of international literature and my personal experience, including performing 2,500 tracheostomies, reveal the following few points. 1. Surgery should be performed in the operating room on an intensive care bed, without transferring the patient to the operating table. 2. The operating surgeon should have personal experience of 500 or more tracheostomies. 3. Hemostasis should be achieved with electrocoagulation. 4. If significant vessels are detected in the surgical field, they should be ligated. 5. There is no need to suture the tracheal wall and surrounding tissues. 6. Preference should be given to a temporary tracheostomy throughout. 7. The anterior tracheal wall opening should be made with a cruciform incision, transecting one tracheal vein. The slides below illustrate the stages of the surgery. 1A. The patient lies supine on the intensive care bed, with a cushion placed under the patient's shoulder blades. 1B. The surgical field is prepared and lined with surgical linens. 1C. We perform a lower tracheostomy below the isthmus of the thyroid gland, at the level of the fourth tracheal vein. 1D. The skin incision on the neck is no more than 2 centimeters. 1E. Careful preventive hemostasis with an electrocautery device, even if there is no obvious bleeding. 1F. On a dry surgical field, we move apart the subcutaneous tissue up to the second fascia of the neck using the bill route and mask a clamp. 2A. Ferric hooks are used to separate the tissues to be the second cervical fascia is incised with the clamp to C. 2D. The protracheal muscles are separated up to the fourth cervical fascia. 2E. All tissues are separated with Ferric hooks to F. The fourth cervical fascia is incised with the clamp and the protracheal space is exposed. 3. The third tracheal ring is grasped with a single prone hook and pulled upward. 3. B. The fourth tracheal ring is incised with a scalpel. 3C. The third interrine space is incised with a scalpel to form a cruciform incision. 3D. The tracheotomy is visible as a cruciform incision. 3E. The cruciform incision is dilated to an oval-shaped aperture. The resulting petals of the anterior tracheal wall ensure good wound healing without stenosis. After removal of the tracheostomy cannula and transition to spontaneous breathing. 3F. A trousseau retractor and a tracheostomy tube are inserted into the wound. Preference should be given to 8 to 8. 5. Depending on the patient's anatomical features. 4A. The guide bougie is removed from the tracheostomy cannula for B. One suture is placed on each edge of the skin wound at the top and bottom for C. Dressings are applied to the wound, and the tracheostomy cannula is secured around the neck with a ribbon for D. The final surgical procedure is a lower tracheostomy. Patents of the Russian Federation for Open Tracheostomy Surgery. 1. Russian Federation Patent for Inventive Method No. 2,409,326 E.P. Ismailov et al. 2011. The method involves using a cruciform approach on the anterior tracheal wall, transecting one tracheal ring. This technique prevents the development of tracheal stenosis and ensures wound sealing by more tightly fitting the tracheostomy cannula with the aperture petals of the anterior tracheal wall. 2. Russian Federation patent for the invention method tracheostomy with drainage of the supracuff space. No. 2,409,326 Ismailov P. et al. 2011. The essence of the method consists of inserting a drainage tube with perforations at its distal end through the superior angle of the anterior tracheal wall aperture. The tube is secured to the skin on the neck. If necessary, one end of the drainage tube is brought out through the nasal passage, passed through the oropharynx and larynx into the trachea, and the other end is brought out through the superior angle of the anterior tracheal wall aperture. This technique allows for the sanitization of the supracuff space and the administration of antiseptic solutions and antibiotics. 3. Method for forming a tracheostomy in cases of coagulopathies. Russian Federation patent. Application number 3,111,490. Patent number 2,815,285. E.P. Ismailov et al. 2024. Method for fixing the edges of the aperture during tracheostomy formation. Russian Federation patent. Application number 2,023,111,491. Patent number 2,815,156. E.P. Ismailov et al. 2024-5. Method for sanitation of the tracheal supracuff space during tracheostomy formation. Russian Federation patent. Application number 2,023,111,489. Patent number 2,815,284. E.P. Ismailov et al. 2024-6. Method for forming a dilatational tracheostomy. Russian Federation patent. Application number 2,023,111,487. Patent number 2,815,283. P. Ismailov et al. 2024. Research results: there were no intraoperative complications. The surgery duration was 10.240, 49 minutes, and blood loss was 5.0 for 0.95 milliliters. Of the 23 patients, 30.43% died. The following diseases were diagnosed according to ICD-10. Pulmonary embolism 126.03 patients, persistent atrial fibrillation 148, 0 to 1, the previous myocardial infarction 125.2, 1 recurrent anterior myocardial infarction 122, 0, 1. Discussion in analysis of the global literature on this issue has shown that tracheostomy can be performed in patients with acute coronary syndrome on continuous mechanical ventilation if indicated, but certain conditions must be met. Performing a tracheostomy in patients with acute coronary syndrome, adults who are taking anticoagulants and have coagulopathy, poses a high risk of bleeding. In such situations, a multidisciplinary approach, cardiologist, anesthesiologist, resuscitator, and surgeon is required to balance the risk of thrombosis and hemorrhage. Basic actions and tactics: risk assessment and anticoagulant history. It is necessary to assess the risk of thrombosis, recent stenting, atrial fibrillation, and bleeding. INR International Normalized Ratio, Act platelet count. Confirm the time of the last dose of anticoagulants, antiplatelet agents. Anticoagulant therapy management for planned delayed tracheostomy. Warfarin. Discontinue at INR greater than 3 to 5. Temporarily stop to INR less than 2.0. If using direct oral anticoagulants dabigatran, rivaroxaban, they are discontinued 24 to 48 hours before surgery. When using unfractionated heparin or low molecular weight heparin for blood thinning, switch to intravenous administration of unfractionated heparin 24 hours before surgery, and then stop 46 hours before surgery. Emergency need for tracheostomy while taking anticoagulants. Bleeding control, antidotes for major bleeding. Use specific antidotes idarucizumab for dabigatran 4-factor prothrombin complex, or fresh frozen plasma local hemostasis. Use the most meticulous surgical technique, electrocoagulation, and hemostatic sponges. Tracheostomy performance considerations, ultrasound navigation. Highly recommended for identifying Bessel's thyroid gland and the cricothyroid membrane. Prior to the procedure to avoid vascular damage. Percutaneous dilatational tracheostomy PDT. Possible with highly skilled operators, as this method is characterized by less tissue damage. However, this technique does not allow for the use of local hemostasis and electrocoagulation. This makes it less preferable for patients with cardiovascular disease who are prone to coagulopathy. Furthermore, this procedure is not possible in patients with a short neck or grade 3 obesity. There is a risk of thyroid damage, especially with thyroid enlargement. A greater risk arises with abnormally positioned vessels, such as the thyroid artery proper, which occurs in 1 in 500 people and originates from the thyrocervical trunk or the aortic arch. Main risks of percutaneous tracheostomy: tracheal injuries. Posterior wall injury, the most dangerous complication, often occurring with blind puncture without fiber optic bronchoscopy. Cartilage injury, fracture of the second tracheal cartilage is possible. Pneumomediastium and pneumothorax, a consequence of tracheal injury that requires monitoring. Tracheal stenosis may develop due to cartilage damage during dilation. Therefore, this tracheostomy technique was not used in our study. We used only open tracheostomy with preemptive hemostasis, open tracheostomy with preemptive hemostasis, open tracheostomy with meticulous preemptive local hemostasis, using the most general surgical technique, electrocoagulation, hemostatic sponges, and gauze trundas at the end of the surgery, with their removal from the wound after 3 days. Allows for minimal blood loss, hemodynamic monitoring, maintaining stable blood pressure BP to reduce the risk of bleeding. Tracheostomy should be performed in the operating room under general anesthesia, with artificial ventilation of using a laryngotracheal tube on an intensive care bed, without transferring the patient to the operating table. Monitoring of oxygen saturation, capnography, electrocardiography, pulse, blood pressure, and respiratory oxygenation index is essential. The operation should be performed by a surgeon or operator with more than 500 tracheostomies. Under personal experience, my personal experience performing tracheostomies includes 2,500 operations. Currently, I have received 6 Russian Federation patents for a tracheostomy method, elements of which have been used in operations for coagulopathy in patients with acute coronary syndrome. Discussion: there is no standard classification for the volume of blood loss during tracheostomy surgery, but the literature suggests that minor bleeding is up to 30 milliliters, moderate bleeding is 30,100 ml, and major bleeding is over 100 milliliters. The first 24 hours after tracheostomy surgery are considered the most dangerous for bleeding, especially in patients with coagulopathy. Conclusion: thus, it becomes clear that performing a tracheostomy procedure on patients with cardiovascular disease, anticoagulants, and coagulopathy carries a high risk of bleeding. However, with adherence to all the stated tactical and technical guidelines, the procedure can be performed. Preference should be given to early open tracheostomy. Before surgery, a coagulogram and thromboelastogram should be assessed. A multidisciplinary approach should be employed, with the patient examined by the hospital's medical director, cardiologist, anesthesiologist, resuscitator, and surgeon. The patient should be prepared for surgery by discontinuing anticoagulants and, if necessary, administering antidotes that neutralize the effect of anticoagulants. Surgical success is dependent on preemptive hemostasis, which can reduce intraoperative blood loss to 5 milliliters. Conclusions: 1. A method for creating a tracheostomy in patients with coagulopathy is covered by Russian patent No. 2,815,285. E.P. Ismailov et al. 2023 demonstrated its effectiveness and reliability in patients with various cardiovascular diseases and coagulation disorders. 2. The time for creating a tracheostomy is 10.0.49 minutes, with blood loss of 5.0 for 0.95 milliliters. 3. Early tracheostomy is preferable, and the procedure should be performed in an operating room on an intensive care bed, under general anesthesia. Thank you for your attention. My contact address: Professor of Evgeny Petrovich Izmailov, IZM63@mail.ru.
Good afternoon, everyone, and thank you for this opportunity. And I'm Dr. Maria Jyoti. I'm a consultant and intervention cardiologist from Apollo Hospital, Banagata Road, Bangalore. We do simple and complex angioplasties. I also visit multiple hospitals, including the nearby hospitals, and I have my own clinic, Arterial via Wellness. Today, I'll be dealing on a topic that is called as the update in cardio physiology. It is one of the review article. As we know that physiological assessment of the coronary artery disease plays a key role in guiding coronary myocardial revascularization. So angiography has its own limitation and in assessment of the severity of lesions. Sometimes the extent of the luminal or the diameter stenosis does not always correlate with the hemodynamic significance of the lesion. It has been established that the physiology is appropriate in the patients with angiographically intermediate stenosis to guide the decision to proceed with the revascularization. Apart from FFR, we do have intravascular imaging like OCT and IVIS and the invasive coronary testing, which is recommended as class 1 recommendation. We have multiple indices which has been there, which include CT-based physiology, pressure wire-based physiology, angiography-based physiology, intravascular imaging-based physiology. It also offers a functional assessment of coronary arteries prior to PCI, during, and also after PCI. So why do we perform? We perform because to determine what is the hemodynamic significance of a native coronary lesions, it is to determine whether the optimal results were obtained after PCI, and also to stratify revascularization like PCI or CABG. In addition to the hyperemic indices, what we know, that is the adenosine FFR, there are non-hyperemic indices like IFR, DPR, RFR. Also, a thorough understanding of the coronary anatomy is essential for treating the coronary artery disease, such as overlapping lesions, foreshortening of vessels, angulations, tortuosity, ectasia, calcified lesion, which may further affect our decision making on lesion severity. In fact, we have image-based physiology, which has demonstrated a promising results with reduction in time, cost, radiation, and patient risk. So as we know, what is FFR? Fractional flow reserve is a gold standard invasive diagnostic test. It is derived by the mean ratio of the distal coronary pressure to the aortic pressure at maximum hyperemia, which is induced by a vasodilator, that is adenosine, so that you're ensuring that the coronary artery is maximally dilated. When the FFR is less than 0.8, it implies the lesion is significantly impairing the blood flow and it is likely to benefit from revascularization. When the FFR is more than 0.8, it implies that the lesion is less likely to benefit from revascularization. Pressure guide wire interrogation is currently recommended now as class 1 level evidence A as a recommendation, and also in multivessel disease who are undergoing PCI, it's class 2A level evidence. We have multiple trials. The most famous was the FAME1, FAME2 trials, which demonstrated that FFR guided PCI significantly reduced the major adverse cardiac events compared to an angiographically guided PCI. FAME2 in particularly also showed a significant benefit of FFR-guided revascularization, helps in improving the outcomes and reducing the need for subsequent procedures. Also had advanced study or BETA trial, defined flare trial, which supported the role of FFR in multivessel disease, reduction in the number of the unnecessary interventions. As we see in our population, we do have disease in patients with diabetes, people with multivessel disease. So, target vessel revascularization and next to what? Should we assess and do all the three vessels or just we go by this trial? Also, FAME 3 shows that the FFR guided PCI had comparable outcomes to CABG patients with triple vessel disease. It is one of my patient which I did few months ago, 67-year-old gentleman. He's a known diabetic and hypertensive. He was strongly positive for ischemia through TMT. So we performed a coronary angiogram with the right radial approach, which shows that the LAD had an intermediate lesion, as we see the ostial LAD. I know that LAD had to be addressed. At the same time, I'm also worried it is in the ostial position, so we made sure we did an FFR. What we understand in the FFR, what you see is the red line is the aortic pressure, what we see, and the green is the distal pressure. So the pressure PA by PD is what we get as 0.77, which is significant because it's less than 0.8. What is the limitation of the FFR? It has its own procedural time that you need to explain the patient. Cost is involved in the patient, wire cost, adenosine. So you need another half an hour to 40 minutes extra. Patient discomfort or side effect from the vasodilator. So we use adenosine either intracoronary 140 micrograms or either we start as an infusion. So because of this, the patient may have, especially you need to ask them, do they feel anything in the chest when we are giving these medicine? And then wait for 5 minutes and then we see the result. Submaximal hyperemia can be there. Sometimes challenges in accurate pressure measurements, precise acquisition to avoid pressure drift, ventricularization of the aorta, and waveform distortion can be there. Mechanical limitations of the pressure wire, suboptimal wire quality can complicate the manipulations in complex anatomies and increase the procedural risk. FFR can be affected by hemodynamic factors, especially in patients when they have a CTO, chronic total occlusion, and well developed collaterals. The pressure drop may be mitigated, leading on to higher values. So, what about in the aortic valve disease? So, what about in other patients? So, a lot of things also varies. We had one study called Target FFR, which was studied by Collison et al. In 2021 to understand what is the use of this in post PCI FFR once you stents the patient. According to his study, one third achieved the FFR value of more than 0.9, whereas one third still had less than 0.8. So, why do you need post PCI FFR? Post PCI intracoronary pressure measurements can identify residual flow lesion in 10 to 36% of these patients despite successfully done PCI. According to Johnson and Collett et al., there were events inside or near the stent after the implantation. Therefore, performing post PCI FFR helps us to reduce the target vessel failure. And also, we found that the vessels also would have a difference. When you do the FFR in the LAD, there may be the FFR value may be a little lesser than the non-LAD like RCA or LCX, which may be like lesser than 0.96, 0.06. So you should be careful with that. Maybe because of the large amount of myocardium which is supplied by the LAD, the amount of the flow which goes through the vessels. Hence, the post-PCA should be vessel specific. Also, mechanisms leading to the low FFR should be elucidated by pressure pullback to differentiate between the focal pressure gradients or diffuse pressure loss. And also, what about in the gender bias? In females, you may get a less FFR because of the females being short and even their muscles. Because of that reason, you may get a very lesser FFR value. What about the IFR? It is an instantaneous wave free flow ratio. It obviates the need of adenosine, do not require a state of maximum hyperemia. Here, IFR is measured during a brief period of the cardiac cycle, and it is also known as the wave free period, which occurs during the diastole when the coronary flow is relatively stable and less affected by changes in myocardial demand. It is calculated using the ratio of the average pressure distal to the lesion to the average pressure proximal to the lesion during this FFR period. This is one of the diagram which actually tells that where is the diastolic period. This is the diastolic period when you have a least hyperemia. This is the systolic period when your mitral valve closes and the aortic opens when you have isovolumetric contraction, then the ejection phase, the isovolumetric relaxation phase, then you have a rapid ejection and a slow, rapid filling, slow filling, and then is a diastasis where the atrial systole. So these are the period where they are considering when the hyperemia is least. So when we consider here the DPFFR is somewhere in the notch of the first PA view to the next one. So likewise, IFR instantaneous wave ratio is the least part where the hyperemia is least. We have again multiple trials. We have define flare, IFR, Swede heart trial. All this demonstrated that it is an alternative to the FFR for assessing the need for revascularization, especially in people with intermediate lesions. Also, the follow-up trials at 1 and 5 years showed IFR-guided procedure were much safer and low events compared to FFR. In Refine RPG study, there were no statistical difference found between them. So, with available techniques with the pressure wire and a thermal dilution sensor, we're able to perform a comprehensive single assessment, not only the coronary circulation, epicardial, microvascular, and vasomotor function. So it scores over, especially when you have a serial diseases, when you have multiple lesion where they prevent crosstalk. In case of aortic stenosis and post-AV patients, also in multiple mitral valve disease, this might help. Also in microvascular dysfunction. Drawbacks, again, it has its own drawbacks because of the smaller gradients can make this more sensitive to noise. Hydrostatic effects can distort measurements, wire drift pullback, can reduce accuracy. Some hemodynamic sensitivity to the blood pressure, heart rate variations can affect the baseline variations. Coming to angiography-based physiology, it is basically done on basis of software which is available based on coronary CT, what we call it as QFR. They take multiple views and multiple softwares are done, and then we devise what is the conclusion. Professor Serious P has shown that the overall performance of this software as compared to wire-based physiology was far superior. Is an advanced non-invasive method. So as I told, there is no need of any hyperemic agents. It is taken from a standard views, images using the advanced software. So it analyzes the flow dynamics of the contrast within the coronary arteries to calculate flow ratio reflecting the lesion's physiological impact. So QFR of less than 0.8 indicates functionally significant lesion. One of the advantages, as I told, it is more faster, it is feasible. Of course, there are some limitation when we do this in osteal lesions, tortuous lesions, and quality of the angiography or the projections, operator interaction also varies. It is one of the gatekeeper of the PCI. So after Favor 2 came the famous Favor 3 China trial, which was done with the QFR, where they have followed more than 3,285 patients over a period of 2 years, where they identified that QFR guided PCI resulted in 35% risk reduction of the MACE compared to angiographic guided PCI. Fire trial sub-analysis done to support QFR showed non-inferiority to wire-based FFR in these elderly patients with bleeding risk. So Aqua trial and Aqua 2 trial. Aqua trial was done in simple lesion, whereas Aqua 2 were done in complex lesion. When you have a CTO lesion, when you have a longer length lesions of more than 28 mm, to put a longer stents, tandem lesion, severe tortuosity, true bifurcation, instant restenosis, and left main disease. FAST FFR was a prospective multi-center trial which actually aimed to assess the accuracy of angiography compared to standard FFR. It worked by generating 3D construction of the coronaries. So this was actually helpful. Likewise, we see many of the patients, especially female population, coming with non-obstructive coronary artery disease. They keep on coming to the hospitals multiple times. They keep undergoing multiple investigations, repeated angiograms, repeated investigation because their coronaries are normal. The larger vessels are normal. It is basically their microvascular small vessel dysfunction. So for them also, we can start using these particular modalities. According to USC updated guidelines, coronary functional testing is now upgraded to class 1B and now extends to recognize that chronic coronary syndrome can be caused due to the dysfunction of microcirculation. Of course, there are limitations despite of its clinical utility, the lack of the consensus on the normal and the pathological ranges of the IMR, which limits the widespread adoption. Coming to CTFFR. CT-FFR is the computed tomography-derived FFR. By merging a three-dimensional reconstruction of these vessels, which you take from a CT coronary angiogram, and then compute with the computational fluid dynamics. Such a fantastic one. So here you only need to understand which vessel need to be stented. So your radiation is also limited. They have a very fast analysis time and an inclusion of distal vessels down to 1.5 mm. Despite the people who are stented, despite patients who are underwent bypasses, multiple vessels, this has been a very wonderful technology. Very simple, as the diagram shows that the blue relates to the higher FFR values representing a normal flow, whereas the red is going to tell that it is the lowest flow in the FFR wherever you have. The values in between will have a varying values. The color coding, which explains the physician, the cardiologist, to guide which is better, which is not. Likewise, one of the example of another patient of tandem lesions of the RCA in the proximal and the mid. So we did an FFR. We were able to understand that, yes, when we did the pressure pullback, there was significant gradient. And after the procedure, we could see that the gradient is better. So this is another CT-FFR patient which we procured in one of the hospitals in Hyderabad. I would like to thank Dr. John Christopher for his valuable addition for this article. So what we understand here is a patient who actually had two lesions on the LAD and the L6. You can see the calcific plaque here. We could see the narrowing. We know already by clinically also the patient is having a significant lesion. Whenever you have tandem lesion, the lesion in the FFR may be insignificant sometimes. So you need to just approach whichever is clinically appropriate. So when we did an FFR, we were able to understand the distal lesion is not that significant. It was only the proximal lesion, which we actually plan to do plasty. Likewise, another patient, we already know the LAD is significantly narrowed and they do have a lesion here in the mid LAD, but at the same time, the diagonal also was a concern whether we are going to do anything or whether it is getting compromised. We did an FFR CT, which actually showed 9. So FFR-CT planner is another important one where it administers the vasodilators before performing the CT-FFR. As they affect the diameter and calculation, it helps in defining the plaque morphology. You get to know what is a thin cap fibroadenoma, which is a risk factor for the MACE. They minimize the radiation. It helps in calculating the FFR post-PCI. Sometimes placing a stent there can affect the patient and cause unnecessary risk. So it recalculates the flow rate to immediately assess the pressure loss after removal of these lesions. Likewise, a syntax-3 revolution trial, ripcord study, all this have involved larger trials like Discover Flow trial, de facto trials. All this were all based on CT-based non-invasive measurements. Unfortunately, it is still yet to come to the smaller cities, or either it's still not available everywhere for a cardiologist to actually decide. We still need to wait for the normal way to go on. In post PCI FFR, a guide about this, a residual gradient or a low FFR within the coronary artery after successful stenting, it can be because of the inadequate stent deployment. There may be a focal gradient across a stent. There may be a dissection or a diffuse disease which was there proximal or distal, because of which it has been happening. So pressure wires can be used before, during, and post PCI. So there is no particular consensus or a guidelines made it, but yes, post stent FFR, if it is more than 0.89, more than 0.9, it is relevant to IVIS MSA of more than 5.4 mm square. So likewise, what we consider is FFR more than 0.9 and IFR or other non-hyperemic conditions, where if you do a procedure, if it is more than 0.9, for it is considered as good enough. So according to Bon Cohn Ku et al., 30% of the angiographically successful lesions had low FFR in the target FFR trial and required additional procedure. Maybe following a stenting, you might need to balloon them with a higher balloon of 0.25 mm. Need not put a stent definitely. If it is required, then you have to see for it. So, but the same FFR-CT has not been validated in multiple other scenarios like coronary stents or bypass grafts, in coronary anomalies, coronary dissection, post-TAVI, in MI, especially acute or recent myocardial infarction, where the heart is stunned or hibernated, unstable angina, in severe calcific plaques leading on to overestimation of luminance stenosis due to heavy calcium burden, which can distort the accuracy of the image yet, and also the high cost. It is still not available in developed countries. Coming to the intravascular ultrasound-based imaging, we do have two. One is OCT and IVUS, which are considered as a class 1 recommendation, and they are best for the complex PCI when we do for left main, true bifurcations, and long lesions, already proven in new ASC 2024 guidelines. Now, what else? What if you combine this IVUS with an FFR or OCT with an FFR? It is an ultimate treat for the cardiologist to operate the patient. A novel method designed for the rapid computation of the FFR using this IVUS image. The goal here is to provide a fast and reliable assessment. And also, it benefits from a high level of automated through artificial intelligence. By this UFR, you're able to identify what is the morphofunctional computation. You get to know the plaque thickness, the plaque burden, the MSA. At the same time, FFR tells what is the lesion which has been important. Application the left main arteries has been a recent topic of interest. Many times, the left main, the trifurcation lesions is very much important. The main compare and the CART study have shown that IVUS and the FFR are valuable, but combining them would offer a more comprehensive assessment, potentially leading on to a better outcome. Many ongoing registries and smaller studies are looking for this still yet to develop. Likewise, virtual flow reserve or either optical flow ratio, they are the one which represents OCT with an FFR. Again, a wonderful thought. And this is derived from the OCT data. So minimal radiation is a very accurate result what you get. OFR integration to virtual PCR eliminate the need of the pressure wires, no need of inducible hyperemia, no discomfort for the patient. Cost is little a concern, which can be overtaken later date. It can be validated against the FFR in both de novo and in instant restenosis lesions. So there were multiple studies already, AFI PCI study with 240 plus patients where they have combined this to know the risk. Combined OCT FFR as a multi-center study which included diabetic patients who underwent angiography with at least one lesion of more than 40 to 80% stenosis on visual angiographic estimation. OCT helped in morphological evaluation of the plaque, especially in thin cap atheroma with functional assessment of these lesions. So these are invasive and cost effective also. Coming to the difference of these things, as we already know, the IVUS is basically for the left main lesions, which you can't negate it. And for the OCT, we can also understand the pullback that there is no need of, there will be a contrast which is being required here. There is a high resolution and better luminal construction and plaque composition. And visualization is better. Compared to the UFR, it has a better penetration and better reference reconstruction. There is no need of contrast. So especially in CKD or a renal patient, it is very useful. And especially for left main. Whereas here in the left main, we don't consider that much. For the ostial left main, of course, with distal left main, we can still consider. This is a table which actually tells what all modalities we are available, we can see. Starting from the cutoff, 0.8 for FFR, others vary from 0.88 to 9. Hyperemia is required especially for FFR and the CT-FFR, otherwise don't require hyperemia anywhere. Procedural time is little increased in case of FFR, but it is not in others. Patient discomfort because of hyperemia, you may get wherever you use FFR combined ones. Procedural cost is actually a little high in FFR, but others it is completely less. These are the trials which have been there. And the percentage of use, as we know, it depends upon which company, Philips or Boston or Abbott. Depending on that, you get the non-in hyperemic measurements in the lab. If you have RFR, it is from the Abbott. If you have a Boston, you get DPR. So these are the analysis what we can understand. What is the limitation at the end of the day? Advances in coronary physiology involves only few center where it is being sponsored or wherever you have a lot of funds with wide experience in QFR analysis. It still can't apply to the places, even in India, even in some other small countries. It's still a thought, it's a debate. In addition, extensive list of exclusion criteria may limit the widespread applicability. And in a MI situation, when a patient is there, you can't wait for these reports to come. Majority of an angiographic-based softwares are currently available only for research purposes only. Angiography-based physiology technology have great potential, but still need to be observed with the caution. Conclusion. Though FFR is a game changer in the assessment of the intermediate coronary artery disease, alternative tools discussed here review present and future alternatives. Some of them simply They simplify the procedure, like avoiding hyperemia, wires, invasive catheterization. While PCA is well accepted for the focal coronary artery disease, the best approach for the patients with significant blockages alongside diffuse diseases, diabetic patients, post graft patients, still under study. Study shows that integrating FFR into clinical practice can lead to treatment reclassification in 30 to 50% of cases. Thank you.
Greeting, dear colleagues. My name is Asya Shadiva. I'm a cardiologist from Russia. I'm also a postgraduate student at the Department of Cardiology of Astrakhan State Medical University. My report is devoted to clinical and functional indicators in patients of all the age groups with arterial hypertension after COVID-19. According to the World Health Organization, 703 million people were aged 65 years or older in 2019, and this number is projected to double to 1.5 billion by 2050. With increasing age, the incidence of age-related diseases increases. The most common disease is hypertension, which is the most significant modifiable risk factor for cardiovascular disease-related mortality and disability. It occurs in more than 60% of people over the age of 60. More than 10 million people die annually from complications of hypertension. The main mechanisms of hypertension in aging are chronic inflammation, neurohumoral dysregulation, oxidative stress, metabolic syndrome, kidney aging with a decrease in closer protein, and the most significant is endothelial dysfunction. Hypertension is the most common comorbidity in patients with COVID-19. Meta-analyses involving over 90 million people have shown that those who have recovered from COVID-19 have a 65-70% higher risk of developing new onset hypertension than uninfected controls. Patients with frailty have a higher risk of complications of hypertension and severe COVID-19. COVID-19 increases the risk of developing myocardial infarction and ischemic stroke by 7-fold within 2 weeks of the acute phase of the disease. The denominator of all the conditions we consider, such as aging, hypertension, and COVID-19, is endothelial dysfunction, which results in most cardiovascular complications. Clinical features of hypertension in elderly and senile patients: increased stiffness of the vascular wall as a result of increased systolic blood pressure and isolated systolic hypertension, decreased sensitivity of baroreceptors, increased variability in blood pressure, postural orthostatic hypertension, postprandial hypertension, frequent occurrence of white coat hypertension, pre-morning hypertension. The aim of our study was to evaluate the main clinical and functional parameters in people over 60 years of age with hypertension after COVID. We examined 98 patients over 60 years of age who were divided into 3 groups. Group 1, 42 people with hypertension and COVID. Group 2, 36 participants with hypertension without COVID. And Group 3, 20 people without hypertension and without COVID, and without significant concomitant pathology. A prospective study was conducted with an assessment of anamnestic data, physical, laboratory, and instrumental research methods. The patients were examined at the time of inclusion in the study and after 6 months. The gender difference in the groups are presented here. There were more women in the first and second groups than men, but the groups were generally comparable in gender. The main complaints in groups 1 and 2 were shortness of breath, weakness, memory loss, headache, cough, anxiety and fear, arthralgia, palpitations. Dyspepsia and hyposmia were found only in patients of the first group in 10% of cases. An assessment of the severity of COVID showed that a more severe course was observed in female participants. Next, we analyzed the laboratory parameters of patients' blood. When evaluating the total blood count in terms of the level of erythrocytes and hemoglobin, no significant differences were found between the groups. The leukocyte count at inclusion was significantly higher in group 1 than in group 2. And control group. Significant differences were also found in dynamic between the first and second group, the first and the control group. An analysis of the biochemical blood test parameters revealed that the levels of D-dimer, C-reactive protein, uric acid, and fibrinogen were significantly higher in group 1. There were no significant difference between the groups in terms of total protein, total bilirubin, ALT, AST, urea, and glucose. In dynamics, after 6 months, a statistical significant decrease in selective protein levels was found from 8 to 4 and 5 milligram per milliliter, uric acid from 321 to 278 millimole per liter, creatinine from 92 up to 90 millimole per liter in patients with hypertension after COVID, but they remained higher than in patients with hypertension and controls, reflecting the nature of the prolonged inflammatory process and kidney damage after COVID-19. Lipid metabolisms disorders were more pronounced in patients with COVID-19. They had higher levels of total cholesterol and low-density lipoproteins at inclusion in the study and after 6 months. We're assessing the achievement of the target blood pressure figures. It was revealed that in group 1, 7% of the participants had blood pressure targets, while in group 2, 16%. Against the background of change in antihypertensive therapy, 18% of patients in group 1 and 27% in group 2 reached the target levels. After 6 months, the targets were achieved in 35% of participants in group 1 and 67% in group 2. Postural orthostatic tachycardia syndrome is an increase in heart rate by 30 or more beats per minute when the body position changes from horizontal to vertical. It is an indicator of impaired function of the autonomic nervous system. In patients in the first group occurred in 31% of patients, in 17% of patients in group 2, and in 10% of patients in the control group. Electrocardiograms in group 1 and 2 respectively showed sinus tachycardia, atrial fibrillation. There were no differences between the groups during the first examination in terms of the frequency of ventricular and supraventricular extrasystoles, as well as blockage of the legs of the GIS bundle. When evaluating the electrocardiogram dynamics after 6 months, atrial fibrillation 20% versus 5 and 5%, sinus tachycardia 35% versus 11%, ventricular extrasystole 19% versus 8%, left ventricular myocardial hypertrophy 58% versus 45 and 8%, violations of repolarization process 33 and 9% versus 60 and 7%. Echocardiography in groups 1 and 2 respectively. Ejection fraction 50% versus 56%. Final diastolic size 56 millimeter versus 54 millimeter. The diameter of the left atrium is 39 and 9 millimeter versus 37 millimeter. Left ventricular dysfunction, 54 and 8% with versus 33 and 3%. Analysis of the daily blood pressure monitoring data showed significantly higher values of the average daily systolic blood pressure of 161 in group 1 compared with group 2, 152. The indicators of these two groups significantly different from the control, 126. The indicators of the average daily DBP did not significantly differ between the first two groups. There were also higher rates of SBP and DBP variability during the day, and the time load index for SBP and DBP in group 1. When assessing the daily index, it was found that in group 1, types with impaired curves of the degree of nocturnal decrease in blood pressure were more common. Thus, as insufficient decrease in nighttime blood pressure was observed in 51 and 6% of patients, and excessive nighttime decrease in blood pressure in 11 and 3%, and a nighttime increase in 66 and 5%, 4 and 2% the participants of the second group. 6 months after inclusion in the study, the complications of the study participants were evaluated. The complication included stroke, myocardial infarction, deep vein thrombosis, pulmonary embolism, as well as the development of refractory hypertension. As a result of the analysis, it was revealed that in participants with COVID-19, complications occurred in 54% of cases, in the group without infection in 7%. Stroke was the most common, 60 and 7%, and 2 and 7%. Pulmonary embolism, 90 and 5%, and 9 and 5%, and 2 and 8%, and the development of refractory hypertension, 31%, and 5 and 7% in groups 1 and 2, respectively. Myocardial infarction and deep venous thrombosis were verified only in patients in group 1. Effective management of patients with hypertension is currently not possible without an assessment of risk factors, among which gender, age, burden, heredity, smoking, sedentary lifestyle, stress, and others are most often identified. Less obvious, but gaining increasing epidemiological importance, are environmental social factors as well as infections agents that can be triggers of destabilization of the course of disease of the cardiovascular system. The presence of post-acute manifestation in patients after 12 weeks may be due to persistent viral damage after the disease, which leads to prolonged retention of complaints. In our study, the most common complaints were shortness of breath, weakness, memory loss, anxiety, and fear. Our data coincide with the results of most researchers on the long-term persistence of shortness of breath, fatigue, and cognitive impairment. Despite the end of the acute period of this disease, signs of chronic inflammation persist for a long time after COVID, which can lead to deterioration in the condition of patients with CVD, and in particular hypertension. Patients who suffered from COVID-19 were significantly more likely to suffer cardiovascular events, mainly due to increased thrombosis. So in our study, within 66 months after the infection, almost every second patient from the group with the infection suffered one or another complication, or he developed refractory hypertension. In all the age groups who have had COVID-19, the course of hypertension is characterized by a more severe clinical course. Due to the significantly frequent development of refractory hypertension and complications, it may be necessary to intensify antihypertensive therapy, review cardiovascular risk, and personalize therapeutic and preventive measures. My report is completed. Dear colleagues, thank you for your attention.
Lifestyle medicine as a foundation of cardiovascular disease prevention. Cardiovascular disease remains the leading cause of death worldwide. Every year, they claim around 80 million lives, and importantly, the majority of these causes are preventable. This graph demonstrates the major risk factor contributing to cardiovascular mortality. The latest contributor is high blood pressure, followed by air pollution, elevated LDL, cholesterol, smoking, and impaired glucose metabolism. It is important to understand that most of the risk factors are modifiable. This means that lifestyle change, prevention strategies, and early intervention can significantly reduce disease burden and mortality. Next slide. Pathophysiological core. At the core of cardiovascular disease are several key pathophysiological mechanisms. The first of chronic low-grade inflammation with continuational damage the vascular wall and promotes atherosclerosis. The second mechanism is endothelial dysfunction. In this condition, the endothelium loses its ability to regulate vascular tone and protect against inflammations. The third component is insulin resistance, which is closely associated with obesity, diabetes, and metabolic syndrome. The diagram illustrates how hyperglycemia, hypercholesterolemia, inflammation, and oxidative stress lead to endothelial injury from cell formation and ultimately atherosclerosis plaque development. Next slide. Obesity as a biological disability. Obesity is now recognized not simply as excess body weight, but a chronic biological disease. Adipose tissue activity affects metabolism and vascular function. It contributes to reduced nitric oxide bioavailability, increased oxidative stress, chronic inflammation, and impaired lipid metabolism. Obesity is also strongly associated with adipokine dysfunction, biological active produced by adipose tissues that regulate appetite, inflammation, and insulin sensitivity. Next slide, life's essential aid. The American Heart Association introduced the concept of life's essential eight key components of cardiovascular health. The behavioral factors inside healthy nutrition, physical activity, evidence of nicotine, and healthy sleep. The metabolic health factor include healthy body weight, lipid control, blood glucose control, and blood pressure management. This framework highlights that cardiovascular prevention requires and lifestyle controlled approach. Nutrition, evidence, and mechanism. One of the most well studied areas of lifestyle medicine is nutrition. The perimetrial demonstrate that the diet reduce the risk of the minor cardiovascular events by approximately 13%. This dietary pattern emphasizes vegetables, fruits, whole grains, olive oil, nuts, and fish. Its beneficial effects are linked to anti-inflammatory properties, improvement of lipid profile, and positive modulation of the gut microbiome. Next slide, physical activity. Multi-system effect. Physical activity has systemic benefit affecting nearly every organ system. Regular activity improves endothelial function, reduces arterial stiffness, and insulin sensitivity. Current recommendations include at 114 minutes of moderate intensity activity of 75 minutes of vigorous intensity activity per week, along with muscle strengthening exercise at least twice weekly. Even moderate increase in physical activity reduce the risk myocardial infarction, stroke, and premature death. Next slide about sleep and sleep and about stress, physiological sleep and social health of also play a major role in cardiovascular disease development. Sleep leads to sympathetic nervous system activation, hormonal dysregulation, and elevated blood pressure. Chronic stress activates the hypothalamic pituitary adrenal axis. The large inter-heart study demonstrates that up to 19 percent of myocardial infarction risk is associated with modifiable factor, including stress and lifestyle behaviors. This next slide. Next slide. Implemental and GEP and conclusion. Despite strong scientific evidence, lifestyle medicine remains remains in clinical practice. The main barriers include poor patient adherence, limit conclusion time, and healthcare systems that focus more on treatment than prevention. In conclusion, lifestyle medicine is foundational, evidence-based, and still significantly under-used and cardiovascular prevention. A comprehensive lifestyle approach can not only extend patients' lifespan, but also substantially improve their quality of life. That's all.
To talk about something related to medicines used in atherosclerosis and myocardial infarction treatment. You know, I have come to the history of treating this disease, and I have found that all the traditional ways in treating atherosclerosis is still at the beginning and need more and more precise delivery systems. And as a pharmacist with the pharmaceutical industry background and nanotechnology formulation practical experience, I have found that I have revised literatures, and I have found that polymeric, biodegradable, polymeric-based nano and microparticles can be effective in treating atherosclerosis. And this there are several strategies we can use for achieving that. First of all, we can work at different levels. First level at lipids lowering. The second, inflammation targeting and reduction, and plaque stability promotion, and for the vessel endothelial cells protection. You know, we have different categories of drugs that are used to treat this disease. And the problem there with the traditional way of application is that the high, the little efficacy, I mean that the amount of drug that can reach to the plaque or to the atherosclerosis are little in comparison with the required effect. And there are a lot of side effects. My work is how I can load these medications like statins and peptides and all the drug categories used for atherosclerosis treatment on nano and microparticles in order to improve the performance of these traditional drugs. So my focus is on these carriers. So we need carriers that are able to be directed to the site of action. I mean, to the microenvironment of the plaque formation at the arteries. So we can load several drugs, small molecules drug like rosuvastatin or statins, and large molecule drugs like peptides. and we can get rid of the side effects. In addition, we can increase the circulation time of the drug within the blood. So we can improve the capacity or the ability of these drugs to achieve these effects. So how can we achieve that? So we, as I told you, I have worked with biodegradable polymeric nanoparticles, and these, and you may ask why polymeric nanoparticles, not lipid nanoparticles, or let me say liposomes, because these can, as a practical experience, I have worked with the formulation aspects, and it is more easier for biodegradable polymeric nanoparticles to be adapted for more size distribution and loading capacity and the surface morphology. With these factors are critical for the efficacy of drug delivery. So we can use these nanoparticles at different ways. We can use it as for small molecules, as I said earlier, for non-steroidal anti-inflammatory, or for statins, or for peptide large molecules. So the next slide, please. So how we can achieve that? This can be achieved by using targeted nanoparticles. I mean, I can make targeting by functionalization of these nanoparticles. This functionalization may be by coating the surface of these nanoparticles by ligands, peptides, or aptamers to improve selectivity. By studying the pathophysiological of the plaque or the atherosclerosis environment, this will be the key factor that I can use in order for me to target my particles towards the specific goal. So I can use different strategies, maybe peptides, maybe functional ligands. Another thing, these nanoparticles can be formulated in such a way to be smart. I mean by smart, to be directed to the microenvironment directly. I mean, when I have ROS oxidative, these nanoparticles can be designed in order to quickly respond to these radicals. So it is one of the strategies to improve or to formulate my nanoparticles in order to target these radicals. Another way, you know that the atherosclerosis is recognized by the inflammatory reaction, and these nanoparticles can be used to target the signaling pathways which are responsible for the plaque formation. So I can, and as a practical experience, I can make core shell nanoparticles. I mean, I can use different polymers with different affinity, with different drug solubility, in order to upload different kinds of drug molecules. I can use, for example, small molecules like statins or non-steroidal anti-inflammatories, or some products like nitroglycerin or so on. I can use it in addition with the same particle, in addition to peptides, I can adapt and manipulate my nanoparticles in order to specify or to centralize my drug molecules either in the core or in the shell. And maybe I can use multi-layer nanoparticles. The purpose of these, and sometimes I can use these nanoparticles in order to make some diagnostic or some, let me say, take a picture or take a view of the affected area. So, and in addition to these multifunctional, I can use these nanoparticles for a sustained release drug. What does it mean by sustained? You know, the pharmacokinetics of most of the traditional drug depends on calculating the dose according to the renal clearance and to the degradation and the excretion of these drugs. The advantage of this, my purpose of this presentation, to view something that when using these polymeric biodegradable, biodegradable, I mean, it is something that these polymers are able to be degraded safely. It is safe to our bodies. So polymeric nanoparticles, when I upload drug, I can have two advantages over the traditional way. The first is I can target the specific region of atherosclerosis, the microenvironment of atherosclerosis. This is the first thing. The other thing is to make sustained release. I mean by sustained release, to make a prolonged circulation time of these nanoparticles, and so that I can make a long duration of treatment without a need to repeat the dose again. And to be more specific, I have found that these nanoparticles may be used in atherosclerosis treatment by targeting another organs like liver. By targeting the liver, the liver and some by gene delivery. I can use some gene editing tools which are uploaded on these nanoparticles to target some tissue or some abnormal genes that are responsible for the LDL, and I can target it in order to give the chance for the liver to clear these LDL from the general circulation. So I can use it either directly to the site of action, or I can direct it to the genetic cause of my problem. So how I will now I will talk to something related to formulation and chemistry, and how I can achieve that. I should, first of all, I should identify my target. Am I going to target the inflammation environment, or the cell, or the artery wall, or the plaque itself, in order to prevent it from perception, from degradation, or giving clogs? So first I should specify the intended use, and select the polymer, and select the active ingredient, and try to make the formulation, and then to test these on vitro, and to monitor the release profile, then to evaluate either in vivo and animals in vivo, or either in human. So these are the main steps in formulating. Next slide, please. Now, it is something related to laboratory job. I can these nanoparticles should be strictly tested in order to evaluate its effective future expected future effect. So I can use this solution in vitro, and I can use the thermal analysis, and I can use the infrared in order to evaluate the interaction between the drug material and the polymer itself. There should be no any interaction between these two elements. I mean the drug and the vector, the carrier. I can evaluate that using differential scanning calorimetry, and I can use infrared FTIR, and I can also evaluate the morphology, which is important for the final effect of my particles morphology by studying with the light microscope or the electron microscope. So these are the aspect of characterization on the lab scales. Next slide, please. I will go to something. The next. I have talked about the next, please. The next. Oh, so I have these particles have many barriers or challenges. First of all, the physiological challenges, you know that quick clearance is expected, and the blood proteins will mask them and try to get rid of them, and so to making some phagocytosis or some masking in order to be clear, or sometimes maybe some immune system response. These are the first physiological barriers. The second, please. The second problem with formulation, which I have worked and I have experienced it practically, that you know that these nanoparticles, upon reaching the circulation, we have something which is called the initial burst. As I told you, I need them to give me the drug in a sustained release manner. So sometimes if the formulation the formulation parameters is not exactly studied, there might be some kind of burst release, which will act as the traditional way, the thing that I don't want. So I try to design my particles in order to have two phases. First, to give the initial dose and to give the required amount of a drug to reach to the site of action. The second is to give the other amount or the other ligands or the other drug particles in a sustained release manner. This is the main objective of my presentation, is to try to give initial and sustained release in order to be able to control the situation. Next slide, please. The other problem with which I have experienced with these nanoparticles, that the loading capacity. You know that I deal with drug material and polymer and formulation environment. So as long as you are able to increase the loading capacity, your particles will be with more precise dose. So one of these challenges are the loading capacity, and these depends on the experience of the formulator and the ability to give the best loading capacity. Next slide, please. The last thing which I'd like to talk about, that during manufacturing or during producing these particles, we usually use some organic solvents like dichloromethane or ether or acetone, or sometimes alcohols. So these organic solvents are used in the processing. So, and usually we try to get rid of them, but the output or the final particles should be evaluated for these residual solvents. And this is one. And by the way, these are, according to my experience, practical experience, the quality and the specificity of these organic solvents have a great impact on the morphology and the loading capacity of these nanoparticles. So to get rid of these residual solvents sometimes represent a challenge, because I'm talking about biodegradable polymers. I mean safe polymers, and these should be free of any residual solvents. So this is one the challenges. Last, some people may ask why I'm using biodegradable polymeric nanoparticles other than the liposomes, which is a phospholipids or something like that. Because as a practical experience, polymeric-based nanoparticles are easier to control in terms of size, morphology, release kinetics, and than the lipid. So to conclude, from my experience, in order to be able to target or to treat atherosclerosis, which is one of the most complicated diseases all over the world, and it has a high mortality rate all over the world. So the thing that initiate me to look for alternative route of administrations or alternative way of application in order to change the pharmacokinetic profile of the old traditional medications. So in order to be able to formulate or to give the exact nanoparticles, you should have a good understanding of the pathophysiological area, a region of your disease like atherosclerosis, and you should have a deep understanding of the medications, I mean the drug molecules or the peptides which are to be used, and you should have a good understanding of the immune system mechanisms, and above all, you should have the ability to manipulate or to control the formulation or the manufacturing parameters in order to get the most effective nanoparticles with the minimum side effects, with the higher load capacity, and free of any impurities like, as I told you, residual solvents. And all of these are a challenge. And I think it is not difficult to achieve that by studying, as I told you, studying all these factors and parameters and put them in place and try to get a new, and I have prepared this presentation because I think, or I feel that reaching such medications or drug delivery system is not too far, and I think by more and the precise work, we can use the ultimate goals of these products. So thank you for your listening.